Hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Michelle Carter, and I'm joined today by MedStar Georgetown University Hospital neurosurgeon Dr. Christopher Kalhorn and neurologist Dr. Fernando Pagan. Dr. Christopher Kalhorn is the co-director of the Movement Disorders Program and director of the Epilepsy, Pediatric, and Functional Neurosurgery Program at MedStar Georgetown. Dr. Fernando Pagan is the co-director of the Movement Disorders Program and the medical director of MedStar Georgetown's National Parkinson's Foundation Center of Excellence, as well as the fellowship director for the Clinical Research Fellowship in Movement Disorders at MedStar Georgetown. Today, we're going to be talking about Parkinson's disease, essential tremor, dystonia, and other movement disorders, and how we can help reduce your symptoms and improve your quality of life. If you'd like to learn more about the management, treatment, and evaluation of Parkinson's and the options for deep brain stimulation or DBS, then stick around. We'll be discussing also the new image technology available at MedStar Georgetown University Hospital. So keep watching, share this broadcast with your friends. Please ask us any questions you have related to movement disorders in the comments below. All right, so thank you for joining us, Dr. Kalhorn and Dr. Pagan. We really appreciate your time. Before we begin the discussion, could you tell our viewers a little bit about yourself and the work you do here at MedStar Health? I'll start with Dr. Kalhorn.
Sure. Thanks so much, Michelle. My name's Dr. Christopher Kalhorn. As you mentioned, I'm the co-director of the Movement Disorder Program here at MedStar Georgetown. I've been with MedStar Georgetown for about 23 years, and Dr. Pagan and I started the Movement Disorder Program at MedStar Georgetown about 23 years ago. I'm most passionate about the work that I perform as a neurosurgeon, as a functional neurosurgeon, to perform deep brain stimulation surgery to help improve the quality of life for our patients with movement disorders.
That's great. Thank you. And Dr. Pagan?
Yes, and I'm Dr. Fernando Pagan, and I've been having the privilege these last 20 plus years now working with Dr. Kalhorn in the movement disorder program, starting it together, and it's really flourished into a significant program with just exceptional clinical care, education through our fellowship program, and research and the translational research that we're doing. But ultimately, it comes down to the patient and helping that patient. And all of our therapies, including the surgical therapies, have continued to improve. The advances that we've made over the last 20 years is amazing. And this, especially just the landscape of in Parkinson's specifically, so many new treatments have just become available within the last 6 months. And hopefully we'll get into all the advances. Just when we talk about deep brain stimulation, just where we were back in the early 2000s, where we are today, it is significantly different. It's an exciting time to be in movement disorders.
That's great. Thank you both again for joining us today. Let's start by explaining movement disorders, giving our audience a little bit of a background on what those are. So I'll direct these to Dr. Pagan. Could you explain movement disorders? What is it like living with movement disorder like Parkinson's disease for most patients? And what are some of the most common symptoms?
So movement disorders is any disorder that causes any abnormal movement disruption. So that could be a slowness in movement, that could be a tremor, that can be a stiffness or rigidity of muscles. So we tend to use the terms for the slowness of movement. Those are Parkinsonian type of disorders. For too much movement, sometimes we'll see tremors or dyskinesias. Or if we see too much stiffness, those are a group of disorders known as dystonia, the abnormal muscle contractions that we do see. But so it depends which movement disorder you have. But the most common one that we definitely see in a movement disorder program is Parkinson's disease. And Parkinson's disease is a neurodegenerative disorder, the second most common neurodegenerative disorder behind Alzheimer's disease. But right now, it's the fastest growing neurodegenerative disorder at the moment. In fact, since the pandemic, we have seen a growth of over 131%. So we continue to see Parkinson's disease exponentially rise compared to the other neurodegenerative disorders. So we're trying to figure out why that is. It's not just because we're getting better at the diagnosis of it. So there's a lot of factors I think involved. But we're still trying to deal with it. But the most important thing about Parkinson's disease is that if you're diagnosed with Parkinson's, we can do something to help improve your quality of life, reduce those tremors, reduce that stiffness, reduce that slowness. And it could be done through medications or surgical options. And our number one goal is to keep patients moving. It doesn't matter whether you're diagnosed with a movement disorder or a memory disorder. The number one goal is to maintain social interaction and maintain movement. Movement is so important. Movement is brain health. And that's what we excel here at Georgetown University Hospital with our medical program and our surgical program. We keep patients moving. We keep patients going back to their normal lives as possible. So they're going to those family gatherings, they're going to those graduations, they're going to those family events and weddings, etc. That's what keeps us going. And if we isolate, the disorders will continue to progress even faster. And maybe that's one of the reasons why we such a rise after the pandemic. We just learned how bad isolationism and inactivity is for brain health. And that's what we got to make sure we do the opposite of that. And that's what we're geared to do here at MedStar Georgetown University Hospital.
Thank you very much. I like that message of hope as well, that there are options available to improving patients' quality of life. So that leads to my next question. Can you tell us a little bit more about the movement disorders program at MedStar Health?
So the movement disorders program is one of the largest programs within our system, especially in the neurosciences. So we have movement disorder specialists not only here at Washington D.C. at MedStar Georgetown University Hospital, but we have multiple satellites. We have movement disorder specialists at Reston in Northern Virginia, in McLean, Virginia. We have the Center for Neurodegenerative Disorders, which is a clinical education and research center. So we've brought out tertiary care, academic medicine right into the community. So we can see patients, we teach residents and fellows there and medical students, and we also do research and a lot of translational research as well. We have movement disorder neurologists in Olney, Maryland, at Montgomery General Hospital, and that's our Montgomery General Hospital. We also have movement disorder specialists at Washington, D.C. in Washington Hospital Center, MedStar Washington Hospital Center, and also MedStar Franklin Square. So we are very, very, there's a total of 15 of us. We have several nurse practitioners. We're up to 4 right now. So it's a huge program. So wherever you're located, there's access to us that we can help bring the most advanced therapies, because that's really one of our main focuses is, can we give the best advanced therapies, especially in Parkinson's disease? 75% of Parkinson's patients never see a movement disorder neurologist, and the majority of Parkinson's patients are never offered the newer advanced therapies, which is astounding. It always kind of baffles me, because I meet somebody who's had Parkinson's for 15 or 20 years, and they're taking medication that was discovered in 1975, the way it was discovered in 1975. And we have so many more advanced therapies, and they've never even been offered something like deep brain stimulation when they start having severe motor fluctuations. And this is when the medicines wear off, they don't work as well as they were before, or you develop dyskinesias, extra movements, and these are levodopa-induced dyskinesias. So this is we're here to help, and we've really made it a point to be in the community as well here at the tertiary center, when you need to come in to get some of these more advanced therapies here in Washington, D.C. But we're out there in the community to help patients. So it's a very encompassing program, and it really is just a delight of all the different people that we do have, and very passionate about making sure that patients get the best treatment as possible.
That's great to hear. Speaking of treatments, could you share what treatments are available and how do these improve a patient's quality of life?
So the main treatment that most people think about in Parkinson's disease is immediate release carbidopa levodopa, the drug that was known as Sinemet, that came out in 1975. But we've seen so many advances of how to deliver that medication. So now we have very long-acting oral medication. It's a true extended release that can last 4 to 6 hours of drug delivery. So the immediate part is a fourth of the medicine, and then over the next 4 to 6 hours, there's a slow release of carbidopa of just levodopa, because it binds to the small intestine where it's absorbed and it slowly releases. It's a medicine called Crexont, not croissant, Crexont, and it's a new medicine that we're learning how to use. The previous longer acting one was a medicine called Rytari, and again, a lot of patients never offer these medications. When things get more difficult to absorb the medication through the stomach, because there's a lot of gastrointestinal problems in patients with Parkinson's to be able to absorb the medication, we now can bypass the stomach altogether, and we can infuse the medication subcutaneously. So we have two subcutaneous infusion pumps now that are currently available. One of them is called Vylev, which is a phosphocarbidopa levodopa that delivers the medicine continuously 24/7 throughout the day. It makes a huge difference for somebody who's having to take medicines multiple times a day, because you just have to set this up once a day. So we've taken a page basically from our endocrinology folks and diabetics who need insulin, that they get insulin throughout the entire day. And then the other one is called Anapgo, which is an apomorphine subcutaneous pump, which is the most potent dopamine agonist there are. And actually, here locally in the 1950s, people in NIH with Parkinson's were getting IV infusions of this drug. Look how long it took to finally get approved. So it took about 70 years to finally get it into our clinics here. And it's been available actually for 30 years in Europe. But if you deliver this medicine continuously throughout the day, it mimics almost just natural dopamine. So you can bypass all the gut and blood-brain barrier issues, and you could lower the medication significantly. And these pumps have been used in Europe for 16 to 18 hours a day. And then when things are, and you can use these treatments just together with DBS as well. So when you're starting to see these motor fluctuations, you can start to offer DBS versus one of these pumps, and they're not mutually exclusive. We have patients with DBS who have these pumps as well, and this is really changing the landscape how we deliver these medications. And just last week, I talked to a patient who was having severe motor fluctuations, dyskinesias. I said, look, we have these two pumps, but we also have the ability to do deep brain stimulation, which still is really the most effective one, especially when we're looking for tremor control and reducing the medicines up to 60%, and having more on time and less off time and better sleep. And there's no fiddling with any devices whatsoever. So sometimes we see a little bit of device fatigue. So they'll start and stop the pumps, and you see the same thing in the diabetic world, even though it is a much better therapeutic entity than just taking pills throughout the day, because that's very difficult to do for most of our patients. And to my surprise, when I gave this catalog of options in front of this patient last week, he said, I want to go for DBS, especially with the new way that we do it. And we'll be talking about that with Dr. Kalhorn a little bit. There's been such big advances. So these are all the different treatments. We have a lot more medical options. We have now devices that can deliver the medicine better. But the operation itself for DBS has gotten better, and then the stimulators themselves are amazing now compared to what we started with back over 20 years ago. Now we've seen with the Medtronic device, we have adaptive DBS, so that we're going to be one of the first in the nation to be able to unleash that technology in some of our patients. So we'll be starting that next week with some of our patients. So you're able to sense directly from the electrode where it is. So depending what the patient is doing and how the medications are working, the DBS adapts whether it needs to be stronger or lower based on the patient's activity. And then just with the Boston Scientific DBS, now we do visual programming, and you could direct the current exactly where you need to do it. So again, I used to sometimes spend 8 hours programming these patients to get the best benefit. You could cut that time into about an hour or 45-minute session, and voila, you have such great technology that you see symptomatic improvement right in front of your face. I always tell my medical students and fellows that we're the best clinic in the world. We can have a patient come in with Parkinson's in a wheelchair and they walk out next to the wheelchair. So that's how dramatic these treatments can be. And then with the St. Jude one, with Abbott, we could have a patient who's out in Southern Maryland, and they could be at home in Southern Maryland, and we could be, they don't have to drive in. We could do the programming right from our office. So this technology, we can specify, and we can see for each individualized treatment for a patient, even in DBS. It's not one size fits all. And we have the ability to use all of these technologies. And I think that's what makes MedStar Georgetown University Hospitals movement disorder program different. Is we're not bound by one product. We use them all. We've learned how to use all three of them, and we probably have the best neurosurgeon in the world too, that knows how to implant all of them. So, and that's why we get along so well, because we have good discussions of what's going to be best for the patient. We individualize the therapy for that patient.
That's awesome. That's great to hear. Thank you very much, Dr. Pagan. At this time, I want to welcome our viewers again. Today, we're discussing Parkinson's disease and other movement disorders and how we can help reduce your symptoms and improve quality of life. I'm joined by neurosurgeon, Dr. Christopher Kalhorn, and neurologist, Dr. Fernando Pagan. If you'd like to learn more, keep watching, share this broadcast with your friends, and ask us any questions in the comments below. Right now, I want to turn to Dr. Kalhorn. Could you share what surgical options are available and what is, go a little bit more in depth about the deep brain stimulation surgery, or DBS?
Yeah, thank you so much. Deep brain stimulation is a very technically advanced operation that we perform for our patients with movement disorders, and it involves the stereotactic implantation of electrodes in a specific target area of the brain, and then coupling those electrodes to an implanted pulse generator, or what we refer to as a neurostimulator. And those electrodes have the effect of blocking the abnormal signals that are coming out of that part of the patient's brain. So in a patient with Parkinson's disease, that is what's called the subthalamic nucleus, or the globus pallidus interna. And for a patient with essential tremor, would be the VIM nucleus of the thalamus. So this operation can help with the full spectrum of motor symptoms that occur in Parkinson's disease, such as stiffness and slowness of movement, tremor, rigidity, bradykinesia, dyskinesias. It can improve periods of good on time on average of about 6 to 7 hours per day, while at the same time we can reduce levodopa dose equivalents by about 30 or 40%. So it's really one of the most effective operations that we have when people are having motor symptoms that are not being well controlled with the various medications that Dr. Pagan outlined.
Okay. And how do you decide if and when a patient might be a good candidate for DBS?
That's a great question, and I really want to emphasize that it's very much a team discussion. So in order to determine whether someone's a good candidate, I very much need the input from Dr. Pagan and his team of movement disorder neurologists. They're really the first point of contact for these patients at MedStar. And oftentimes it's when the patients are experiencing motor symptoms that are not well controlled with medication alone, or they start having less and less periods of time where the medication's working for them, less periods of on time, more periods of off time, or dyskinesias, then we start thinking about deep brain stimulation surgery as a potential option. So we want to make sure also that our patients don't have significant cognitive impairment, such that they wouldn't be a good candidate for DBS surgery. But it's very much a discussion that we have with our movement disorder neurologists. Oftentimes, people may hear that there's a so-called window of time where it's appropriate to consider DBS as a therapy. I think when we first started doing this surgery back in the mid-90s, we were really only operating on patients who were very advanced in terms of their Parkinson's disease. And I think the trend now has shifted much more toward considering DBS when not when someone's newly diagnosed either, because usually we can control their symptoms well medically at that point in time. But once they start to develop symptoms that are not well controlled medically, then it's probably appropriate that you at least have a discussion with your movement disorder neurologist about whether or not DBS is an appropriate consideration.
This is really important because this is Parkinson's Awareness Month, so we should make patients with Parkinson's disease aware of this fact that about 25 to 40% of all Parkinson's patients are actually candidates for deep brain stimulation, but yet only 3%, less than 3% have actually gotten DBS. So there's an unmet need here, and I think there's been education, or maybe there's a little bit of fear of this surgery, and we could talk a little bit about how I think we're uncoupling that fear or mitigating that fear that's out there. But the number one statement that I see as a neurologist is, Dr. Pagan, I should have done this sooner. You've been telling me for years, and I finally did it, but I should have done this sooner because I have such significant control of my life again. So I think that's, and I think that's probably because by history we waited to the very end. But if you have already had Parkinson's for 3 years and you're now in those motor fluctuations, that automatically makes you a candidate once you see those motor fluctuations. So if you want to take control of your Parkinson's symptoms, you want to take advantage and have a better quality of life, I think this is something you should consider rather than just adding more and more and more medicines all the time. And we do have that capability or devices, and there's always down the road room for more medicines, everything else. But especially for when you look at quality of life, the only thing that really significantly improves that quality of life dramatically has always been DBS compared to that of optimized medicines or adding more medicines. So I think that's a really important fact that needs to be said. And then for patients for essential tremor, the majority of patients don't tolerate the medicines, and we really haven't had any major advances in the treatment of essential tremor in terms of medical therapies. So again, if you can't drink, you can't dress, you're not eating soup anymore, you're making a mess while you're eating, DBS is a great option to be able to really give you that ability. And then for the dystonias, it's more compassionate care use, but it's amazing what we can do with patients with generalized dystonia, and that's a lot more rare, but we definitely are able to help people with this. So those are different movements, and it's just sometimes getting to the right conversation and understanding how the procedure is done. I think that will ultimately make the difference. But I think there's a fear out there, and maybe Dr. Kalhorn can talk a little bit how he can mitigate that fear nowadays, because it's really exciting what he's doing here at MedStar Georgetown University Hospital.
Thank you very much. Dr. Pagan, Dr. Kalhorn, that's a good segue. Could you tell us a little bit more about the new MRIS at MedStar Georgetown and the benefits of MRIS over traditional DBS?
Absolutely. Thanks for that question. And it really dovetails with Fernando's comments. We're very fortunate at MedStar Georgetown to have an MRIS suite, or an intraoperative MRI suite. We're one of only a few centers in the entire world that has this technology. And we really have the most advanced operating room right now anywhere in the world. MRIS is a mobile MRI magnet combined with an operating room. It's a 3 Tesla MRI machine, which tracks in a ceiling mounted system directly to the patient in the operating room. And the way this has really revolutionized deep brain stimulation surgery at MedStar Georgetown is that in the past, we would have our patients come in for DBS surgery in the off medication state. For many of our Parkinson's patients, this is a very, very difficult thing to do. They have a hard time getting by as it is without being off their medication. But when they have to stop their medication the night before surgery and come in that state, oftentimes they're frozen, they have tremor, stiffness, and we would have them awake for the portions of the procedure where we would, after we implanted the electrodes, to test them to make sure that they weren't having any motor side effects. And this is about a 5-hour operation. So this could be very, very difficult for our patients to be awake for portions of that surgery and to be off of their medication. So Dr. Pagan and I and others began thinking, how else can we do this procedure? So what IMRIS allows us to do is to use very high resolution MRI to visualize the subthalamic nucleus, which is a very small target and traditionally had been difficult to visualize on a traditional MRI. And we use that high resolution MRI imaging so that our patients can come into the hospital on their medication and they're asleep for the entire procedure. We're able to directly visualize that target nucleus and to implant the electrodes very precisely with MRI navigation exactly where we want them to be with sub-millimeter accuracy. This is an operation that requires very accurate placement of the electrodes. So not only has this approach made things more comfortable for our patients, it's improved the accuracy of the operation for our patients, and it's also made it safer because we can visualize if there's any bleeding in the brain or anything unusual, we can see that at real time with the MRI machine. So we're just very fortunate to have this technology available to us here at MedStar Georgetown, and it's really been a tremendous benefit to our patients with movement disorders who are undergoing deep brain stimulation surgery.
Thank
So,
you.
so
Oh,
Dr. Kalhorn, a practical question for our patients. How long is the procedure now to be able to do the implantation bilaterally now? Because when we first started, sometimes you hear centers 20 years ago it would take 12 hours. They would just do one side, with all the intraoperative recording. You got it down to about 5 hours bilaterally while the patient's awake and doing everything else. So how long does it take now for this with this procedure for the bilateral placement?
That's a great question. It takes us about 4 hours now to implant the electrodes bilaterally. And for a brain surgery, this operation just involves a one-night stay in our neurosurgery unit here at the Verstandig Pavilion at MedStar Georgetown. So almost all of our patients go home the day after their deep brain stimulation surgery. And then the programming or adjustment of the settings on the device is an outpatient procedure, which is non-invasive. So we really have been able to reduce our surgical times with this IMRIS approach, this intraoperative MRI approach. So we're really seeing a number of benefits from, as I mentioned, accuracy of lead placement, our patients being able to be asleep for the surgery, and improving the safety profile of the operation. So a number of huge advantages for our patients.
that's great to
So
hear. Dr. Calhoun, I know we have to end with you so you can go back to clinic. So I want to be respectful of your time and let you go back to seeing patients, but we'll continue our Facebook Live with Dr. Pagan at this time.
Thank you so much. It was a real pleasure being here. It's great to be able to work with Fernando and to see what our team has grown into over the years. And I really appreciate the opportunity to be with everyone today for this important discussion. Thank you so much.
Thank you very much. We appreciate it. All right.
So I think what Chris said is just amazing to me as a neurologist, because it was to see the evolution of this surgical procedure where it was going in some institutions as much as 12 hours with the patient in the off state. Now that we can do both sides at the same time in about 4 hours with significant accuracy, with our patients comfortable, they're not in the off state, they're asleep. I can tell you as a neurologist, when I have now started talking about to our patients about DBS and the new way that we can do it, the same patients that were saying no way are now saying, okay, I'll do it. So definitely being awake while you're getting an electrical placed in your brain and putting a hole in your brain made a big difference for patients. And that maybe that's why we only have seen 2 to 3% of patients actually do this surgery. So now that we have better techniques, and I think, in my opinion, a more humane to do way to deliver this surgery with much better accuracy, I can tell you that uh, now with the last year of being able to do it this way, since we opened up the Verstagnet Pavilion, I see a difference in my patients post-operatively. So that's I think that's a big statement there that is different. And if you take a look at you hear a lot of people talking about uh, incisionless with focused ultrasound. That procedure can last 6 to 12 hours. It's a lot longer procedure, and you're only doing one side. So I think there's and you're destroying brain tissue versus you're modulating brain tissue with DBS. So those are the big differences between the two. There may be some people who are very appropriate to do the focus ultrasound, but I do think our procedure, I think, is a little bit more humane at the moment, and you can put and patients are asleep and much more comfortable, and you're not in an MRI machine for hours and hours. So there are differences, and I think it's always important to take a look at what has happened. And I do think that probably in the future, the so-called awake microelectrode recording, the way we traditionally have done, will hopefully be obsolete because this is a lot more accurate and more humane for patients. So I think we're really lucky to have that here at MedStar Georgetown University Hospital. And you put that surgical procedure in advancements together with the advancements that I mentioned earlier with all the different deep brain stimulation devices. I think that's really exciting that we really could just sit down with each patient and individualize which technology is going to be best for that particular patient. And it's a real exciting time. I mean, I just give kudos to Medtronic and Boston Scientific and Abbott for all the advances that they've done in DBS over the years. So it's just been amazing to see that as well, and together with the additional therapies. And ultimately, a lot of research is happening. So we're seeing the first trials now using techniques exactly as Dr. Kalhorn is mentioning, where you could inject a viral vector with mRNA to increase growth factors in the brain to help patients maintain the health of those neurons. And some of those patients who were the initial patients that got those therapies have also gotten DBS and are doing great. So again, these treatments are not mutually exclusive. A lot of research is going on, and we're definitely heading into the future to be able to help patients every single day. I think just over the past 20 years, our treatments for Parkinson's has continued to improve, and we continue to see enhancements in our treatments year after year. So it's a real exciting time in neurodegenerative disorders to be able to help these patients with all of these different conditions.
That's great to hear. Just one final question to wrap up. Dr. Pagan, could you share how you treat patients after they've received that DBS surgery?
So that's the fun part. When after the DBS surgery, we usually see the patients about 4 weeks after implantation of the electrodes, usually somewhere between the 4 to 6 week mark. And that's when we start to do programming. If we're now with the different devices, you can record directly where the electrodes are to see where the abnormal brain activity is. So it's called deep brain stimulation, but we put them in a nuclei when you don't have enough dopamine. These nuclei are hyperactive, so we put a stimulation there to drown that out, and that restores function again in patients. So the restore of function is what we do best in movement disorder programs, and it mimics the effect if we had given levodopa. So we start to stimulate there to see a restoration of normal function, reduction of tremor, reduction of stiffness and slowness. So it's really the motor symptoms that we look for improvement. And somebody has to be levodopa responsive, even though it's not working as well as before, to be a good candidate. But it definitely mimics the effect of levodopa. And once we do get the best programming, and we could do that by recording and then stimulating and seeing that, and that's what the Percept device does so well. And again, adaptive DBS is coming, and we're going to be learning how to do that over the next week, and we'll be implementing that here at MedStar Georgetown University Hospital. One of the first programs clinically has been done. A lot of research has been done over the last decade on how to do this out in the West Coast, but we're bringing it into the East Coast, so we're really happy about that. Or you can visualize the new technology with Boston Scientific. You see the electrodes, so the MRIs that Dr. Kalhorn gets intraoperatively. We can put that together with the electrode with the Boston Scientific, and we can now modulate the stimulation there. So once we have done the different program with whatever device we have, and we see that we have good control of symptoms, right there, that's when we kind of start to bring down the medications. So usually within the first visit, we're lowering the medication about 30 to 60% of the levodopa that they were taking before. So it's a significant decrease in the amount of medicines that they're taking, but we'll continue to follow these patients every 4 to 6 weeks, especially during the first 3 months, and make little adjustments and tweak the stimulation a little bit, tweak the medicines down a little bit. So there is about a 3 to 4 month process while we're adjusting the medications, adjusting the stimulation before a patient feels a lot better. It'll be fun to see if some of these new tools that are now available to us and just FDA cleared, would that make the programming a little bit easier or a little bit better for patients over time. And again, these are things that we're going to be learning now that we have clearance of this, and especially when you can, you're able to actually visualize that where the actual electrode is in the nuclei, then you have the best control of the multiple contacts that we can program to mitigate all the different symptoms that a patient may have, whether it's Parkinson's disease or essential tremor or dystonia. So we're still learning a lot, but these new tools that we have really do translate into giving a better quality of life for our patients.
That's great to hear. Thank you so much, Dr. Pagan. Thanks again for joining us today. That wraps up our broadcast. I want to give thanks to Dr. Kalhorn and Dr. Pagan for joining us and sharing your expertise and giving us hope about all of the treatment and advancements that are available for patients and helping them get to a better quality of life. We really appreciate hearing about that. Thanks to all of our viewers as well for tuning in. For more information, please call 202-444-9012. We're going to put that information in the comments as well. Thanks again for joining us, and have a great day.
Thanks for having us. Bye-bye.
Thanks.